It's very important for you to remember or review the anatomy of the heart and the blood flow of the heart. There is test questions in regards to this, so make sure that you're familiar with that. You're familiar how the blood comes in through the superior vena cava to the right atrium, right ventricle, out the pulmonary arteries to the lungs, coming back through the left ventricle, left atrium to the left ventricle and out through the body. There are 4 cardiac valves that maintain unidirectional blood flow through the chambers of the heart. The valves also assist in producing the pressure gradient needed between the chambers for the blood to flow through the heart. Again, this picture kind of describes the cardiac function of the heart. There is a review of the coronary circulation. Know that when we are talking about myocardial infarcts, it's not the main arteries, right? It's not that pulmonary artery or in the aorta or anywhere in that. It's the coronary sinus or the coronary right coronary arteries. It's those little ones that feed into the muscle. So if there's a myocardial infarct, it's one of those little ones that is getting to the tissue or the muscle of the heart where the infarct is happening. It's very important for you to be familiar with or to remember proper cardiac assessment, where on the chest that you'll be listening for the different areas of the heart. Remember, in your health assessment, you learned to listen in order of ape to man, the aortic, the pulmonic, the Erb's point, the tricuspid, the mitral valves. The vibrations produced by vascular walls, flowing blood, heart muscle, heart valves, they create sound waves. And so those are the different places where you'll be listening for those sounds. The first and second heart sounds are best heard with the diaphragm of the stethoscope, whereas the third and fourth sounds are best heard with the bell of the stethoscope. The first heart sound is known as S1. That's the lub sound, or that's the closure of the tricuspid and mitral valves, heard best in the 5th intercostal space and the left midclavicular line. It's the beginning of the ventricular systole. The second heart sound, known as S2 or the dub sound, is closure of the pulmonic and aortic valves, best heard in the 2nd intercostal space of the left or right sternal border. It is the beginning of the ventricular diastole. The S3 sound is low-pitched, best heard in the 5th intercostal space, left midclavicular line. It occurs immediately after S2. It produces a lub-dubba sound. There is in Canvas different heart sounds that you can listen to that will help identify those abnormal sounds that you may hear. Okay, more on cardiac diagnostic studies. That 12-lead EKG or ECG, this is non-invasive test. It's usually preliminary to all other tests. It's least invasive, least expensive. It does evaluate the electrical activity of the heart in 12 or more leads. Then there's a Holter monitor. This test is used to detect suspected dysrhythmias. Data is collected in an outpatient ambulatory setting for 24 to 48 hours. So these patients are usually sent home with this device. Exercise tolerance test or stress test. This is non-invasive test in which the patient is connected to an EKG machine while exercising to identify if there's any ischemic events that occur. Then you have the pharmacological stress testing. If a patient is unable to do physical activity or perform physical activity, then pharmacological stress tests can be done. This is done in conjunction with an echocardiography. Medications can be given that help increase the heart rate or make cardiac changes while it's read on the machine. Nuclear stress test. This is given intravenous, and the images are compared to the patient at rest. Then there's chest x-rays that can be done. That is to look at the silhouette of the heart or the location and size of the heart, the positioning of it. It can detect cardiomegaly. It can detect any extrapulmonary fluid that may be retained due to circulation issues of the heart. The echocardiography is a non-invasive acoustic imaging method used to visualize the structures of the heart. The echocardiography is used to assess valvular function, evaluate congenital defects, measure size of cardiac chambers, and evaluate cardiac disease progression. Then there is the transesophageal echocardiogram. This test provides ultrasonic imaging of the heart from a view from behind the heart. So it actually goes through your esophagus. So this is given in a procedural environment. The patient has an IV, they come in NPO, they're lightly sedated. A scope with an ultrasound device is put through their esophagus to see the backside of the heart to see a different angle. The multigated blood pool study, or the MUGA study. This study is used to assess the left ventricular function. An isotope is injected and images of the heart are taken during systole and diastole to assess the ejection fraction of the heart. A PET scan can also be done. A PET scan is a non-invasive way to study cardiac tissue perfusion. Radioactive isotopes are injected intravenously to help with the imaging. Then there is the cardiac magnetic resonance imaging. That's like an MRI, basically. It's non-invasive. It's used to evaluate the tissue, structures, and blood flow. MRI cannot be performed on patients that have pacemakers or implantable defibrillators, cochlear implants, or any type of brain clips. If they've had a previous brain clipping, like an aneurysm clipped or something like that, those patients are not candidates for an MRI. Okay, so during a cardiac catheterization and arteriography, there's different things that can be looked at or studied. It used to be that it can be left or right-sided catheterization. It used to be very common that it went through the groin. More modern technology or modern procedures, they can be done through the brachial artery of the arm, which is quicker recovery. It's showing to be a better way, better for the patient, less side effects. So electrophysiology study. I don't think that's the right way to say it. It's an invasive procedure that involves an introduction of an electrode catheter percutaneously from the peripheral vein or artery into the cardiac chamber or sinuses. So basically it causes electrical stimulation to the heart. These studies aid in recording intracardiac ECGs, diagnostic cardiac conduction, evaluating the effectiveness of any antidysrhythmic medications, determining the proper choice of pacemaker programming, and mapping of cardiac conduction system before an ablation. So we talked about ablation before and how they go in and they basically cause electrical activity in the heart, and they try to stimulate a type of arrhythmia that the patient's been having so that they can see exactly what part of the heart, or map out what part of the heart is having that before they go and ablate it. So cardiac catheterization angiography is an invasive procedure that can be divided into two stages: right-sided or left-sided catheterization. Cardiac catheterization is used to confirm and evaluate the severity of lesions within the coronary arteries, to assess left ventricular function, and to measure pressures of the chambers of the heart, cardiac output, and blood gas content. So a right-sided catheterization is performed by placing a pulmonary artery catheter in the femoral or brachial vein, and then carefully advancing it into the right atrium and right ventricle in the pulmonary artery. Whereas the left-sided catheterization is performed to visualize the coronary arteries and the area and extent of lesions within the native vessel walls and bypass grafts. It evaluates angina-related spasms to located areas of the infarct and to perform interventions such as percutaneous angioplasty, stent placement. Left-sided catheterization is performed by cannulation of the femoral, brachial, or radial artery. So based on the patient's 12-lead ECG, the 12-lead ECG would tell us where there is a potential problem of the heart, where there's an electrical abnormality. And from there, the doctors will decide if they do left-sided, right-sided, or both-sided catheterization to get into the heart. Again, the right-sided gives us the right side of the heart, whereas the left side is more to fix problems. That's more for angioplasties or stent placements. I thought this would be a good place to talk about post-catheterization care. It's not technically a diagnostic study, but it's something that we do after a diagnostic study's been done. So the patients, again, they could be left-sided or right-sided or both. It could be femoral, brachial, or radial arteries that have been accessed. Specifically for this, I'm going to focus on the groin access. So the patient will need to be on bed rest. Their head of the bed should be no higher than 30 degrees. Your job as the nurse is to continually monitor for any signs of bleeding in the site that was accessed. Remember, it was an artery that was accessed. When they remove the device or the catheter, they put like an angio seal or some type of device that closes it off so that bleeding will not occur, but you still have to assess for it. And if you think about it, especially for the groin access, the femoral access, you're going to want to assess those distal pulses, right? So you're going to be looking to see like the 6Ps. Remember, let me see if I can remember them. Pulseless, pale, pain, the pins and needle feeling, paralysis, and I forget what the other one is, but you're basically looking and assessing that site. So if they only had a right-sided or if they only had a left-sided, then you'll be assessing the lower extremities and comparing one side to the other. You want a good baseline assessment so that you have something to compare it to in case bleeding does happen. Antiplatelet drugs after the procedure. That's usually after they've had the post-catheterization. This can be heparin, this can be Plavix, this can be the doctor's preference. Let's see. So these patients, you want them to be no more than 30 degrees. They're going to have to stay that way for 6 to 8 hours. We're assessing constantly for signs and symptoms of bleeding or any kind of complications or blood flow interruption to the affected extremity. But you want to encourage fluids on these patients if appropriate. Remember, if they've gone through a cardiac catheterization, they've had dye. So patients that are diabetic or that have impaired renal disease will have to be very closely monitored. If they're on metformin, remember that's contraindicated in this cardiac catheterization dye is contraindicated in patients that take metformin. So those are just some things to consider. This picture here shows pressure that's applied post-catheterization. If the angio-seal or if stitching is not used at closure, then manual pressure for 15 to 30 minutes after the catheter's been released is what we do for these patients. There are commercial devices like shown here, a FemStop, to apply pressure so that the nurse doesn't get tired or have just 15 to 30 minutes of standing there. Depending on the diagnostic study, the results, and patient status, they're usually discharged within 6 to 8 hours of a procedure. There is a table or box 13-4, which is nursing care after cardiac catheterization and angiography. Common lab tests that you'll see with these patients post-procedure or for, diagnostic purposes. Obviously, your hemoglobin and hematocrit. Specifically, if there's been any antiplatelet or antithrombolytic therapy, we want to make sure that those numbers are staying or maintaining. And then serum electrolyte. Electrolytes are important in maintaining the function of the cardiac conduction system. We know that electricity is what keeps the heart the electrical impulses is what keeps the heart going, and that these specific electrolytes have an effect on the cardiac conduction system. Imbalances in sodium, potassium, calcium, and magnesium can result in cardiac dysrhythmias as well.